Welcome to this explainer. We're diving straight into the brand new 2026 Surviving Sepsis Campaign Guidelines to break down exactly what's new, what's changed, and what absolutely remains the clinical standard. If you work anywhere near acute or critical care, grab a coffee because this is the definitive, evidence-based update you're going to need for your daily practice. Let's get right into it.
But first, let's zoom out for a second. 13.7 million. That's how many lives sepsis claims globally every single year. It's a staggering number, right? So we really have to ask ourselves, how do we optimize treatment for a time-sensitive medical emergency of this massive scale? Well, the data is crystal clear here. Prompt recognition and highly structured, evidence-based interventions are the exact levers we need to pull to bring that mortality rate down.
To make sense of all this dense medical taxonomy, we're going to follow a hypothetical patient's journey chronologically through 5 core phases. First, the 12-9 statements overview. Second, screening, infection, and hemodynamics. Third, respiratory and adjunctive therapies. Fourth, supportive care and goals. And finally, transitions and long-term outcomes.
Section 1, the 129 statements overview. Okay, let's look at the big picture of this massive update put together by a 69-member international panel.
The 2026 guidelines give us a seriously powerful framework. We're talking exactly 129 precise clinical statements broken down into 9 core categories. Let's pace through how this is built. We've got 16 statements just for screening and early management, and then 25 for infection. For stabilization, there are 23 statements covering hemodynamic management and 14 for respiratory support. Then it gets into the nuances, 8 statements for adjunctive therapies, and 13 for additional supportive management. And looking toward the future, we have 8 covering goals of care, 16 for transitions of care, and 6 essential statements for long-term outcomes. It's literally a cradle-to-grave roadmap.
Section 2, screening, infection, and hemodynamics. Imagine a patient crashing in the back of an ambulance. This is where our clinical pathway actually begins.
You know the old QSOFA tool? Well, the guidelines are actively discouraging it now because of its poor sensitivity. Instead, they are firmly giving the green light to comprehensive screening tools like the 7-parameter National Early Warning Score, or NEWS. NEWS looks at a much broader physiological picture: respiratory rate, oxygen saturation, supplemental oxygen use, temp, systolic blood pressure, heart rate, and level of consciousness. Because it's a multi-system approach, it just vastly outperforms the limited 3 criteria of QSOFA.
Now this is a real game changer. There's a brand new conditional recommendation for pre-hospital antibiotics. If you've got an adult with definite or probable septic shock in an ambulance and you know the hospital is more than an hour away, the panel determined that you should probably just get those antibiotics on board immediately. Honestly, this is a massive, practice-changing update for emergency medical services.
Timing is everything, right? So we group antimicrobial administration into 3 action buckets. You've got immediate treatment for definite shock, a strict 1-hour window for probable sepsis, and a 3-hour rapid investigation window for possible sepsis cases. For that last group, possible sepsis without shock, you don't just sit on your hands. You use that 3-hour window to rapidly assess what's going on. If you still suspect an infection after that rapid workup, you absolutely must administer antimicrobials before that 3-hour clock runs out.
The bedrock of hemodynamic stabilization is still exactly what you'd expect. You have to administer at least 30 milliliters per kilogram of balanced IV crystalloids within the first 3 hours for sepsis-induced hypoperfusion. But, and this is crucial, the 2026 update added some vital remarks here. They're reminding us to calculate this based on ideal body weight for patients with a BMI over 30 and to perform frequent, ongoing reassessments. We really want to avoid the deadly harms of over-resuscitation.
We all know the standard mean arterial pressure target is 65 millimeters of mercury. But check this out, there's a critical new nuance. For patients aged 65 and older, they conditionally suggest a lower, permissive target of 60 to 65 to actually improve long-term mortality. Think about it. If you're using norepinephrine, pushing an older patient's blood pressure higher than it naturally needs to be just increases undesirable effects. Permissive hypotension in this specific demographic is a major takeaway.
Section 3, respiratory and adjunctive therapies. Let's move our hypothetical patient into the ICU and see how we handle respiratory support.
For acute hypoxemic respiratory failure, high-flow nasal cannula is now conditionally preferred over non-invasive positive pressure ventilation. Oh, and awake-prone positioning is newly suggested for non-intubated patients. Plus, if your patient requires mechanical ventilation but doesn't actually have ARDS, the guidelines now suggest low tidal volumes of 6 to 8 milliliters per kilogram of ideal body weight. They're recognizing that ARDS is frequently underdiagnosed in this specific population.
Okay, let's talk about a fascinating nuance regarding mechanically ventilated adults. If they are in a unit with low antimicrobial resistance, there's now a conditional recommendation for selective digestive decontamination, or SDD. This basically means administering non-absorbable topical antimicrobials to the oropharynx and upper GI tract. It specifically targets the bad pathogenic aerobic bacteria while preserving the anaerobic gut bacteria that we need for digestion and immune function. It's showing a probable reduction in short-term mortality, which is huge.
When it comes to adjuncts, you really have to look out for clinical red flags. Take empiric antifungal therapy. It is now formally recommended against unless you're dealing with very specific, high-risk criteria. Actually, scratch that. It used to be split into 2 separate recommendations, but the 2026 panel completely streamlined it. Now, you should only even consider empiric antifungals on a strict case-by-case basis for patients with severe immunosuppression, prolonged hospitalizations, or known specific intra-abdominal sources of infection.
Section 4. Supportive care and goals. Our patient is finally stabilizing, so we're entering the critical deresuscitation phase.
Tissue edema is deadly. To actively combat it, the new guidelines map out a step-by-step active fluid removal process. First step, halt fluid escalation. Second step, administer diuretics. And if that's not cutting it, utilize ultrafiltration. Once your patient is off escalating doses of vasopressors and doesn't need ongoing volume expansion, you've got to pivot. Fluid overload impairs oxygen delivery and drives organ dysfunction, so aggressively moving into this evacuation phase is just absolutely vital.
What's really cool here is that this specific edition directly responds to input from patient representatives. They placed an incredibly high value on avoiding fluid overload during this evacuation phase. It is just incredibly powerful to see patient voices directly shaping an international clinical guideline like this. Even though the data on mortality benefit was kind of uncertain, the sheer value patients placed on avoiding profound, uncomfortable edema totally tipped the scales for this conditional recommendation. Parallel to the clinical care, we have to talk about goals of care. You need to initiate these discussions with patients and families within the first 72 hours. You don't wait for standardized triggers or mandatory palliative care consults. Sepsis is a massive, life-altering event. The guidelines emphasize that you don't need a formal protocol to start talking. It just requires clinician-guided palliative integration early in the ICU stay and making sure the health system facilitates advanced directives as they recover.
Section 5. Transitions and long-term outcomes. Our patient is finally ready for discharge. Let's look at the recovery phase. Sepsis absolutely does not end at the hospital doors. Survivors routinely face immense physical, cognitive, and emotional hurdles. We're talking profound weakness, lingering brain fog, and serious emotional trauma, including PTSD and depression. We can't just pat them on the back for surviving the acute shock and send them on their way. They need ongoing management.
To bridge this really vulnerable gap, the guidelines firmly demand structured handoffs. A fragmented discharge is a dangerous discharge, right? We need pharmacist-led medication reconciliation to handle all those complex new ICU meds. We need to make sure primary care providers are fully briefed. And we must actively screen for cognitive and mental health symptoms. We have to ensure the survival we fought so incredibly hard for in the ICU actually translates into a meaningful quality of life at home.
Knowing the evidence is just half the battle. So the question is, how are you going to apply these life-saving updates to rapidly recognize, treat, and transition the very next sepsis patient during your shift? From utilizing news instead of QSOFA to adjusting those fluid removal and MAP targets, these 129 statements provide the definitive playbook. The next time that monitor alarms, you have the evidence. How will you use it?